Hello, everyone. I want to welcome you to the 2022 APATS Symposium. I want to thank you for attending. Thank you for your interest in this presentation. Thank you to the APATS committee for allowing me to share this with the group. Something that I find I enjoy doing, and I find value in this as an athletic trainer. So, I appreciate the opportunity to come here, share things that I've been doing, and hopefully share some joy and help others maybe find some value in this topic as well. So the presentation will be on injury prevention methods. My name is Kyle Gallagher. And injury prevention, I know, can be somewhat of a hot topic, somewhat polarizing, and we're not going to be debating methods too much in this, what's right and wrong. It's just kind of giving you some structure and maybe some ideas about moving forward and things of that nature. So to start off, I don't have any financial or other associations with any manufacturers or commercial products. With that being said, the structure is based off of a framework from the National Academy of Sports Medicine movement screens. And I do have my NASM certifications for corrective exercise and performance exercise. And this program is, again, going to be mainly built off those frameworks and structures. But the statements and opinions in this presentation are just solely mine. I'm not being paid to push anything to you. So just use your discretion with anything that I say and anything that's contained in this presentation. So to go over our learning objectives for the day, we're first going to look at what we're already doing for injury prevention, some things that you may not even know that you are doing that are considered injury prevention. The second is to learn about a few programs that are already in use that you may not be aware of or maybe are aware of, and just give a little bit of background on those programs. The third goal is to introduce, maybe refresh the overhead squat assessment, the weight-bearing lunge assessment, and a thoracic rotation assessment. And then lastly, we'll go over a sample program that I've used in the past, just to give you some ideas where to go if you're looking to start to incorporate injury prevention methods in your practice as an athletic trainer. Other than the theme of this conference, including prevention, why else are we looking at this? Why is this important, you'd say? Taken from the content outline and the practice analysis for the 8th and 7th editions here, you can see that the domains clearly cover and are focused on injury prevention. Domain 1 in the current edition specifically mentions the word prevention. So it's really a core foundation of athletic training and what it is to be an athletic trainer. Now, kind of in a transition between the 7th and 8th domains here, but not a lot changes. Just some verbiage. Injury and illness prevention is changed to risk reduction in the domain names. But taking a look down at the task statements, really the verbiage stays the same. Screening instruments, using screening instruments, and to aid in risk reduction. That's why this topic is important to me, is because it is in the very foundation of being an athletic trainer in the domain names. And if we continue to take a look here at the second domain, while it's not as implicit, there are still principles in the second domain that are important to prevention. Taking a look at examinations, assessments, and then this physical examination. And I really would say the tests that we do, the screenings that we do would fall under this physical examination. Maybe not as much as some of the special tests and other ways of evaluating an injury, but I still think that they're valid and important in this context. So what are some things that we're doing already as athletic trainers for injury prevention? Things you may not even realize. When we look at the PPEs, we're looking to find injuries, find previous issues. Maybe they need to see a doc to prevent further injury, or we need to start them with rehab. Maybe we are just going to need to tape them for a little bit while they continue with their rehab. And that's really a part of injury prevention. Preventing further injury, preventing something from before causing issues in the future, or giving prophylactic bracing and taping. Another one that's kind of often overlooked is our policies and procedures. They may include heat illness protocols to prevent heat illness injuries, or cold weather policies, or anything along those lines in our policies and procedures are really qualify for injury prevention. It may not be in the normal sense that people think when they hear injury prevention, but still in the domain. Again, equipment fittings using braces, ankle braces, knee braces, all these different types of equipment to help prevent injury or further injury. Building connections with our campus health, counseling, nutrition, or just the community health counseling or nutrition. And then creating education for our student athletes, our coaches, our parents, teachers, really anyone involved in the umbrella of participation in athletics. So now we're going to take a look at some injury prevention programs that are already in use. These programs are designed more for teams or groups of athletes. And the first one that we're going to look at is the FIFA 11 Plus. This is an injury prevention program which has been designed to prevent football or soccer injuries, depending on where you're from. It was developed by a group of experts, and it really built on programs that were already in existence, including the PEP program, which we'll talk about next. This program takes about 20 minutes to complete, and it's designed to be performed just twice a week. You don't really need any extra equipment, maybe some cones and a partner. And it is comprised of 15 exercises into 3 different components. The first component is simple running exercises: cutting, change of direction, deceleration, proper landing, and then you transition into a strength and plyometric and balance exercises where you're focusing on your core strength, maybe some planks, eccentric control. Here you can see them doing some Nordic hamstrings, proprioception exercises as well. And then you go into the last component, which is more running exercises, high speed, change of direction type running. The next program, the PEP program, sorry that this slide is a little bit busy, you don't have to read it all, I'll kind of cover the gist of it. So this program is broken up into 5 different sections. The first section is a warm-up, very similar to the FIFA 11 Plus, jogging, shuttling, backwards run, things of that nature. Transition into a strength, again, walking lunges, Nordic hamstrings, some calf raises. The next section is plyometric. We can do some line hops, some single leg hops, maybe practice some headers, some scissor kicks, things along those lines. And then you transition into agilities, running with a 3-step deceleration, some lateral, diagonal running, bounding. And then at this point, you would get into your typical sport training practice. The last component, and one that differs from the FIFA 11 Plus, is section 5, which is stretching. And this is post-practice, a lower extremity post-training stretch is included in the PEP program. And the last program that we'll talk about is the Sports Metrics program. This is a credentialed program. There's not a lot of information out freely available on the structure. But what is out there, it is essentially the same type of framework as the 2 programs previously discussed. This program was included in a systematic review by Noyes in 2015, and their findings were actually presented at the American Academy of Orthopedic Surgeons via poster in 2018, and that poster accredited 2 programs to have decreased ACL injury and increased neuromuscular movement for female athletes. So the Sports Metrics and the PEP program, which we just talked about, have been studied and given the stamp of approval for at least decreased ACL and increased neuromuscular movement in female athletes. So those programs were a great start, especially if you're looking for group or team-based programs. But I feel like a lot more of our population and situations are going to be individual-based. And to create an individually based injury prevention program, it's really going to start with testing those individuals. And there are a bunch of different testing methods out right now, including the FMS, which is a battery of tests to grade movement quality. Those grades put you into a zone, and you kind of correct from there. The grading system is categorical, And there is a lot of referring to sports medicine professionals if there's pain present. This test was not designed specifically for sports medicine. It's really broad. Strength and conditioning professionals, coaches, and athletic trainers, physiotherapists use this test. It's very, very widely used and very, very well known. The NASM Fusionetics program is another battery of tests. It's very encompassing, includes goniometry. The program is then kind of spit out after you input all of the test results. It may include practitioner interventions, some stretching, activation, and a little bit more individualized exercises. It's a little bit longer of an evaluation process, but the program is very, very well rounded. I'd probably say the gold standard, at least from what I've been exposed to. The overhead squat is a component of each of the above FMS and NASM programs. It's a quick movement assessment on stability, movement quality, muscle imbalances, and I think a lot of professionals use this as well outside of just sports medicine. Weight-bearing lunge is, maybe somewhat of a new or novel test. It's a great way to assess dorsiflexion. If you're a follower of the kinetic chain and belief in that system, the toe and ankle are the first stops in that. So I think it can be really useful when screening athletes. And then goniometry, obviously, is something that we learn in our basic classes, measuring those range of motions at each joint one at a time. Obviously, this can be very time consuming, but you can also get a lot of valuable information if you do have the time for this. So I just want to take a brief pause, talk a little bit about why I chose this topic and kind of set up the direction for the rest of this presentation. In 2016, I had the unique opportunity to move overseas and work as an athletic trainer. I took a position at an international high school in Guangzhou, China. I was there for 2 years, and during this time was really able to get a sense for the need for athletic trainers overseas, to link up with the athletic trainers here, the APATs, and to really get a sense for the international setting of athletic trainers and the possibilities. After 2 years there, I accepted a position working with the Chinese Olympic wrestling team as they prepared for the 2020 Olympic Games in Tokyo. This setting and these athletes were very, very different from where I had just come from. These athletes, they didn't have class, they didn't have work. There wasn't a lot of outside influence on them. They were there to be athletes and to be the best athletes that they could. This meant that they had plenty of time on their hand to go through any programs to get better, to focus on their sport. And any time that we gave them a rehab program or strength program or anything to do, they're really good at adhering to those programs and doing what we asked. So it was really nice, to have that opportunity to work with these athletes. Why I chose this topic, I always like to create something. I always like to try to make my job easier. And, if I can help prevent injuries, I think that makes my job easier. The volume is then lower. I can spend a lot more quality time with individuals who may need it. So there's a lot of things that go into designing an injury prevention program. We'll kind of go over those steps here briefly. The first thing, what are you trying to affect? Are you trying to affect performance, wellness, strength, flexibility, some other metric? Really got to find this idea at a macro level to then start branching down into the smaller components. For us as sports medicine professionals, a lot of the time, this is identifying an injury or dysfunction that we see a lot or have observed on individuals. At this point, we want to break that dysfunction or injury down into the simplest idea. What's causing this? Is it neuromuscular? Is it previous injury? Is it arthrokinetic? And then are those even modifiable? If you looked at femoral anteversion for a Q angle, probably not going to be able to modify that too much, versus decreased internal rotation on a baseball player. Now that's something that we might be able to modify a little bit easier. So after you have identified those, you want to set goals, and you want to set realistic and attainable goals. You can't just have blanket statements of, hey, we're going to have no ACLs because of this program. We're going to have no concussions because of this program. Those really aren't attainable. Unfortunately, those injuries do happen with participation in sports, and setting those goals at the beginning are going to set your program up for failure. Some of the things you got to look at are these risk factors. What are the risk factors for these injuries or dysfunction? If your injury is sunburn, a risk factor may be being outside. On a more realistic example, ACL injuries, plenty of research and documentation on medial knee collapse and their effect on ACL tears. So then after that, you want to select a test battery. What are we trying to measure? Is it going to give us a good representation of this injury or dysfunction? Again, previous example, looking at medial knee collapse. If you did an overhead squat, that's been shown to give reliable and realistic interpretation of medial knee collapse. Now, if you wanted to do a hop test or a bench press, that's probably not going to be very reliable for medial knee collapse. So selecting that test battery and making sure that it's going to give you data that's relevant is important. The thing you got to look at with these test battery is what do you need? What equipment do you need? You probably got to live within your means. You're not going to be able to have the most fancy equipment at some of your settings. So maybe an overhead squat is going to be more, is going to be easier, or is going to be better for your situation for this process of program design. Once you've done the tests, you got a bunch of data now, and you got to interpret that data. What does it mean? How can we really look at this and compare it with others to show that this test battery and these data are pertinent to our program and what we're trying to affect? After that, you got to have an intervention, right? So you've identified these issues. What are you going to do to try to correct them or to modify them? And the very last thing is you got to retest and compare. Did your intervention work? Do you need to remove things, add things? It's really important to do that last part to make sure that what you've done is actually affecting, good or bad, what you're trying to affect. So now that we've gone through all the different steps that we looked at for creating a program, we're going to kind of focus in on exactly my thought process and how we created this individual program for these athletes. It starts off with setting our goals. To pick the goals that we want to set. We can't prevent everything, so setting goals like no ACL tears, no ankle sprains, no shoulder pain, no low back pain is just not realistic. And you're just setting your program up for failure if you set those goals from the beginning. So finding these attainable, realistic goals is the first step. And how do you find those? Well, you really got to break down all the different factors to see what you can affect to set those goals. So, starting off, you got the extrinsic versus the intrinsic factors. The extrinsic, looking at the environment, the training, the equipment, the nutrition. Those are all things that we felt we weren't going to be able to control or have an influence on with our population. We weren't going to be able to, make an argument for changing the food served at training table. There wasn't going to be a lot of new equipment brought in, on our suggestion. The volume of training wasn't going to be changed as much as we pleaded. So we really had to kind of eliminate a lot of these intrinsic factors. So we just started to focus on intrinsic factors. Inside that little bubble, there's two subgroups as well, modifiable versus non-modifiable. Intrinsic, non-modifiable characteristics might be age, gender, genetics. Again, these were things that we weren't going to be able to control very much. We weren't going to be able to say, hey, a lot of these athletes are a little bit old. We should bring in some younger kids. We weren't going to be able to change their previous injury history. So we really couldn't select that as something we were going to focus on. We had to deal with the athletes that we had, and that's who we were going to get. So these intrinsic modifiable factors, what were those? What could we affect? Well, the team already had a system in place for muscular strength, for muscular endurance. They didn't really have a flexibility program that they worked specifically on. The sport, wrestling, really incorporated a lot of flexibility, but it wasn't something they worked on specifically. And we found these opportunities. We had 4 sessions a day. pre-practice and post-practice where we could affect these athletes in some capacity. And I really wanted to focus on flexibility in those sessions, individual flexibility as well. Their dynamic warm-up was great. They were doing very sport-specific and very dynamic and difficult tasks to warm their body up for the training session, but they kind of just jumped right into it. They didn't really do any activation, any central nervous system wake up. They kind of just jumped right into these advanced movements, which I think put a lot of stress on their bodies. And the second thing was, at the end of practice, they would kind of just get up and head to their room, sit on their phone, go straight to training tables. There really wasn't a cool down at all for the activities that they just performed. So we really wanted to work on flexibility in those sessions that we were given. So this is kind of a continuation of the previous slide, setting these goals based on these modifiable factors. So looking at the first goal of our program that we wanted to address was ankle range of motion. We wanted to find out if these guys had enough ankle range of motion, because if they were lacking, there's plenty of documentation saying, decreased ankle range of motion can lead to knee valgus, can lead to knee pain, hip pain, really just issues all the way up the kinetic chain from this lacking of dorsiflexion. And there's modifications all the way up that could be increasing the risk for injury. The second goal was the knee valgus. This is kind of a secondary effect from this ankle range of motion. But when just looking at them, their running form was atrocious. The knees were collapsing as they ran. And this just caused added stress on the knee, which is already one of the most injured body parts in our sport. So if we could somehow test and see these athletes have knee valgus and then implement a program to correct that, we felt like we could be decreasing the risk for injury and just the overall stress on their joints. The third, again, based on observation in their previous lifting regimen, their thoracic rotation was just a global issue throughout the team. Their programs were very sagittal plane based and not a lot of transverse plane activities. So they were very solid, but lacked functional mobility in rotation. So that was something that we really wanted to address, specifically because the sport demands of wrestling demand it. And then the last thing was just finding these muscle imbalances that maybe have gone undiagnosed. And the method behind this was their training was volume, volume, volume. And if they have these tiny little muscle imbalances, with that amount of volume, those stresses can just be amplified. So we really wanted to kind of correct those so that the volume of their training didn't have a chance to amplify those muscle imbalances and cause added stress on more joints than needed. So after we've kind of identified these four goals, how are we going to test them? How are we going to standardize them? Well, the first one is the overhead squat. And this has been shown as a good indicator and good test for testing dorsiflexion. It also gives you good readings on knee valgus and any muscle imbalances. So that accomplishes three of our goals in just one test. So for the weight-bearing lunge, we chose that because it's just a confirmation of that dorsiflexion measurement. If you're unfamiliar with the weight-bearing lunge test, we'll go over it in a little bit. And this also allowed us to compare the lower extremity side to side for any joint or muscle imbalances. So just a confirmation on that overhead squat and any dorsiflexion findings. And then the thoracic rotation, again, that was just due to the build of the athletes in the previous strength regimen. We were able to identify those ranges of motion through this thoracic rotation strength regimen. So again, we've got four goals, and those are all covered here with this testing battery, and they've all been documented as reasonable and good assessments for those issues. So now that we have selected our testing battery, we'll just give a little bit more information on the tests, how to perform them, and maybe the rationale behind choosing them. So for the overhead squat, rationale number one was my certifications through the NASM. I felt very comfortable using this assessment on scoring it. and I really believe in the ideology behind it and what you're trying to find with this test. Outside of my opinion, it's been shown to demonstrate good sensitivity and reliability for assessing dorsiflexion, which was, the first goal that we're trying to affect. And it's also been shown to demonstrate good reliability in assessing medial knee displacement, which was our second goal that we're trying to affect. And compared to the FMS, I felt that this was a better scoring system, being able to check individual joints and checkpoints versus throwing a global movement into a category. Now, a little bit of more theory behind it, and this kind of gets into the fourth goal, those neuromuscular dysfunctions. So the overhead squat is designed to identify these dysfunctions through key kinetic checkpoints, kinetic chain checkpoints, looking at the ankles, knees, hips, low back. This overhead squat evaluates flexibility, balance, core strength, and neuromuscular control globally. It can also identify altered length tissue relationships of muscles, ligaments, and tendons. Depending on what joint you're looking at, can identify altered force couple relationships as well as altered arthrokinematics. One of the drawbacks that I hear a lot about the overhead squat is, if you can cue the test into correction, it's probably not a good assessment. And I think that's a big gripe with the overhead squat, saying, hey, keep your knees out or don't let your feet turn out. If you're able to tell the athlete to not do that and they're able to do that, are you getting good information? And is the information that you got, valid? Despite all that, in my history, I still feel like the overhead squat is able to give us the data we're looking for with the means that we have. So the next slide is getting a little bit into the actual test. So when you're testing someone, and they're not shown here, but I always like to have them in, somewhat close-fitting clothes. You don't want baggy shirts and baggy shorts or pants because you really have to identify the ankles, the knees, and the hips. So having tight-fitting clothing is one of the first steps for the patient. And here, like I said, it's not shown, but I like to have them in socks. I feel if you've got them in feet, they can get a little bit more grip, and those dysfunctions may not show up, versus having them on somewhat of a slippery surface, a gym, a hardwood, really allows for those musculature imbalances to overcome any friction that you get from bare feet. So the overhead squat assessment, you're really looking at them from three different views: the anterior, the lateral, and the posterior. You have them stand with their hands over their head, the arms lined up with their ear, and they should just be looking straight ahead. Their feet pointed straight ahead. This might not feel comfortable to them, but that's very important to have them start with their feet pointed straight ahead. And their foot, ankle, knee, lumbo, pelvic, hip should all be in a neutral position. Again, with the shoes off, but I like to have the socks on. So at this point, you would have the athlete go down into a squat at their own natural pace, roughly to the height of a chair, and then have them return back up to the starting position. You have them do this, 5, 6 repetitions while you observe from each position, the front, laterally, and posteriorly. It's important to obtain as much information as possible, so it's going to require you to walk around them as they're performing these squats so that you can observe the difference, kinetic chain spots to see if there's any compensations. You're looking for compensations at the foot. You're looking for frontal plane deviations at the knee, sagittal, and frontal plane at the lumbo pelvic hip complex, and excessive sagittal plane in the upper body. What does that mean? So here's just a little bit of a scoring sheet that I used. Again, this is taken a lot from the NASM and their overhead squat assessment, but you're looking at, from the anterior view, does their foot turn out? Does their foot flatten? Is their knee moving in? Is their knee moving out? As you transition to the lateral view, you're looking, are their arms falling forward? Are they having excessive trunk forward lean? Is their low back arching? Is their low back rounding? And then from the posterior, is there a weight shift? Are they shifting over to one side, or is their heel coming up off of the ground during the squat? So now that we have identified these key kinetic chain checkpoints, what do they mean and how can we build a program off of this? So starting at the first kinetic chain checkpoint, the foot, one of the compensations we might observe is the foot turning out. And what this could mean is they've probably got some overactive muscles, including the soleus, the lateral gastroc, bicep femoris, and TFL, when compared to the medial gastroc, medial hamstring, and glute med, gracilis, popliteus. Those might be underactive, so that altered relationship is causing that foot to turn out. You can also notice that the foot flattens. Again, overactive muscles include peroneals, lateral gastroc, bicep femoris, and TFL, where underactive might include the anterior tib, posterior tib, medial gastroc, and glute medius. So you don't have to have this information stored on hand, but just kind of keep this information in your head, and we'll go over what it means as a global program towards the end. The next kinetic chain checkpoint will be the knee. Is the knee moving inward? If it is, then you've probably got some overactive muscles, including the adductor, bicep femoris, TFL, lateral gastroc, compared to some underactive muscles being the glute medius, VMO, medial hamstring, medial gastroc. On the flip side, if the knees are moving out, you might have an overactive piriformis, biceps femoris, TFL, glute minimus and medius, where the adductor, medial hamstring, and glute max might be underactive. Again, just kind of keep that in the back of your mind. We'll go over it more, what they mean, and how to build off that later. So after you finish with the anterior view, you move over to the lateral view. With this, you're really just focusing on the lumbopelvic hip complex, looking at the low back, if it rounds or arches. If it arches, there's a possible overactive muscles being the hip flexor complex, erector spinae, and lats, where the glute maximus, hamstrings, and some of the internal core stabilizers might be underactive. On the flip side, if the low back rounds, you might have overactive hamstrings, adductor, rectus, and external obliques, where the glute max, erector, spinae, and those intrinsic core stabilizers still might be underactive. So you would just mark this on your sheet, and we would come back to it later. So here, still from the lateral view, we're taking a look at two different checkpoints, the lumbopelvic hip complex and the upper body. And these two compensations are often confused and hard to distinguish. So hopefully after the slide, you'll feel a little more comfortable in identifying each of these when appropriate. So looking at the lumbopelvic hip complex and the compensation of excessive forward lean, with this, you'd probably be looking at overactive calves, hip flexor complex, as well as some of the abdominals being overactive, with some underactive muscles being the anterior tib, glute max, and erector spinae. And this is shown with the picture on the left here. And if you draw a straight line following the line of the tib as well as the line of the spine, you'd really ideally like to keep these as parallel as possible as they go down into the overhead squat. If they start to intersect pretty close to the knee, you're probably having some excessive forward lean from the trunk. When comparing that to the arms fall forward, the picture doesn't show the line to the tib, but if you could just imagine that line going up and comparing it to the trunk line, there isn't going to be intersection very close to the body. The intersection really comes from the arms, where the arms are falling out of line with that spine. So that's the main difference between the two, and distinguishing them when building your program is important because they involve different muscles. So for the arms fall forward, you'd really be looking at overactive muscles being the lats, the pecs, teres major, and then the underactive muscles being the mid to lower trap, rhomboids, rotator cuff, and the deltoid. So again, very important to be able to distinguish between these two. And I think these pictures do a good job of showing the difference between them. So as we come to the last view, the posterior view, we're taking a look at 2 checkpoints, the foot and the lumbopelvic hip complex. For the foot, we're really just trying to see if the heels come up off the ground. If they do, probable overactive muscles include the soleus. Underactive muscles include the anterior tibialis. For the lumbopelvic hip complex, we're looking for an asymmetrical weight shift. This is a lot, so bear with me as I walk through this. So as you can see in the picture here, they are shifting their weight to the left. So in this scenario, they would have overactive muscles of the adductor complex and the TFL on the left side, and their piriformis, biceps femoris, and glute med on the right side would be overactive. And then underactive muscles would be their left glute medius and their right adductor complex. So yeah, you don't have to memorize all that. There are cheat sheets if you're going to use this that make it really easy to build programs off of. So here we see an example score sheet of the overhead squat. Just taking a look at it, it shows both feet turn out, both knees move in, their arms fall forward, and there's a weight shift to the left. And this is good information to have. We know these compensations are happening, but the interpretation of this data is what's most important. Why are these compensations happening? With the feet turning out, is it muscle imbalances like we just talked about? Is it an overactive soleus and lateral gastroc with underactive medial structures? Could be. Could there be arthrokinetic issues at the talocrural joint? Could be. Could there be previous injury history causing them? Yeah, very well could be as well. So we know those compensations are happening, but we've got to figure out why. Going to the knees, moving in, we're going to ask the same questions. Are these muscle imbalances at the hip, in the thigh? Is there something at the foot causing these to occur? We know that they're happening and we've identified them, but now we got to figure out why. And then the last one we'll look at briefly is a weight shift. This could be a combination of all the above. Are they shifting weight because they've got poor dorsiflexion? Are they shifting weight because of previous injury? Are there issues at the hip on one side, on the other side? So while this information is good, it doesn't really paint the whole picture quite yet. And that's why we've identified a couple more tests to help us build this picture. So now we introduce the knee to wall. And we chose this test because it gives us a better representation of side-to-side deficits. While the overhead squat can tell us if there is possibly dorsiflexion issues, this will really tell us side-to-side exactly what those issues are. And this is a quantitative measure, where the other one was not necessarily. You're putting a number on the measurement with this test, which is great. And again, research has shown this to have high validity and reliability as a test for dorsiflexion. Getting into the test setup, all you really need is a wall with a 90-degree angle from the floor to the wall. You can put some athletic tape marked down from the wall out every centimeter up to 20 centimeters. And then what you do is just have the athlete pick a centimeter, put their toe and heel on the line, and then have them press forward to try to touch their knee to the wall. If they're able to touch the knee to the wall, you have them back up 1 centimeter and try again. If they're unable to touch their knee to the wall, or their heel comes up off the ground while trying to touch the wall, you would just mark the previous instance where they were able to touch the wall. And then you would record that centimeter mark and then test the opposite sides that you're able to compare. And with this, 2 things to kind of keep in mind. Pictures here show kneeling and standing. There isn't much research that I found to show one is superior to the other. You can also tell in the kneeling that the hands are behind the back. Some test protocols allow for their hands to be on the wall or behind the back or on the knee. You try to want to make sure that they're not pushing the knee forward, that they're adding compensations or pulling on something to pull themselves forward. So just kind of things that you have to think about. This isn't as standardized as the overhead squat. And here we have a simple score sheet for the knee to wall test, left foot, right foot. I have an asymmetry, and just to see if there's any pain noted that we may need to look into it a little bit more. Okay, so here we have some examples of knee-to-wall tests as well as our overhead squat assessment from before. If we take a look at the top right knee-to-wall, looking at that left foot at 11 centimeters and that right foot being at 4 centimeters with a difference of 7 centimeters. And I've color-coded these to kind of show what we're looking for and what may need to be improved. I'll go over the colors here at the end of this slide. So now we would move on to the next athlete, the next example, that left foot being 9, which is colored yellow, that right foot being 11 again in green. Now this asymmetry is actually colored green because there's only 2 centimeters difference here. That's not really a big concern to us, the asymmetry wise, but they're still lacking some dorsiflexion here on that left foot. And then down to the bottom right example, their left foot being 4 in red and right foot being 6 in yellow. That asymmetry, again, is not a big issue, but globally their numbers are down and they're lacking dorsiflexion on both sides. What could be causing these? Multiple things. Again, muscle imbalances, structural, orthokinetic, maybe a previous injury. Face value, I'm looking at these and I see someone who's got an 11 and a 4. I'm automatically thinking that there's probably a previous injury to that right side causing that severe decrease on one side versus the other. So I would probably question the athlete and look more into that, their injury history. If I had the athlete on the bottom left with a 9 and 11, probably looking more muscle imbalances. They've got good dorsiflexion, but they're just kind of lacking that end range here on the left side. There could be sport training influencing that. Could be dominant versus non-dominant, but again, my initial thought would be looking at muscle imbalances and measuring those side to side. And then here on the bottom right, I think this could probably be more structural. They're globally down. They've probably got an issue down at the talocrural joint where they're not able to get that roll and joint mechanics that they need to get that dorsiflexion we're looking for. Again, that's face value. You got to look into a little bit more, but when you combine these with the overhead squat, you get a little bit better of a picture and how you can build a program. So to talk more about the colors and the numbers, what do they mean and how do you interpret those? So when looking at weight-bearing dorsiflexion, we want to be anywhere from 7 to 34 degrees of dorsiflexion. But we're measuring in centimeters, so we need to convert that centimeters to dorsiflexion. Well, depending on the foot size and the length of the tibia, an average degree per centimeter is 3.5. So if they score a 1 on the knee to wall, they've got 3.5 degrees of dorsiflexion. So in this instance, when we say 7 to 34 is normal, we really want to see our athletes in a 2 to 10 degree arc. For our population, the demands on the sport and for the elite athlete, we're bumping that 2 a little bit higher. So that's how I've color-coded these. If they're a 10 and above, then they're okay. As you can see, the 11s are green here. I've moved that yellow threshold to 6. So if they're anywhere from 0 to 5, they're red and they really need improvement on that dorsiflexion. And if they're anywhere from 6 centimeters to 9 centimeters, they're still within a normal average for the population. But for our population, we're looking for that to be a little bit higher. So that's how I've color-coded these here. And then symmetries over 2, but lower than 6 would be yellow. And then over 7 is red. But that's just kind of something I picked and not really backed by anything. So again, at this very last little point here, the symmetry and correlating with the overhead squat assessment. So now that we've got these, we've got to take a look at what could be causing these two and causing them in conjunction together. So now I've come to the last test, the thoracolumbar rotation test. There isn't a lot of documentation on this test, so really kind of just had to comb through some of the research and papers. Combine that with some protocols we found to kind of create our own assessment tool. So through that combing process, we found a paper by Newman who states that each thoracic vertebra can rotate approximately 3 degrees on average. So when you combine that with the 12 that we have, we get about 30 to 35 degrees of total rotation from the thoracic spine. Now, the first thoracic vertebra behaves like the cervical vertebra, and the 10th, 11th, and 12th behave more like the lumbar vertebra. And those lumbar get about 2 degrees of rotation, so we get about 12 from those 5 as well. When you combine those, we get about 45 degrees of rotation in each direction. And some of the papers we found stated that a lack of thoracic rotation can lead to increased lumbar rotation. And when those lumbar rotation get greater than 3 degrees, that can lead to damage in the articular surface, tear in the collagen fibers that make up the disc between those lumbar vertebrae. And if you're any follower of back pain, you hear these terms brought up quite a bit. So we really wanted to focus in and see where this rotation was coming from. Is it an over rotation at thoracic, or at the lumbar, or maybe even an under at one of those 2 locations as well? So for this test, we had the athlete seated on a bench. We placed a foam roller between their knees to help limit any compensations that could come from the lower extremity. We placed the dowel behind their back, and they held it up against their back with their creases of their elbows. We felt that this would limit any compensation coming from the shoulder joint and give us a better representation of true spinal rotation. They were seated in the middle of a semicircle. Starting at the middle of that semicircle, we marked athletic tape out at 30 and 60 degrees and gave those areas created zones. So from 0 to 30 degrees was zone 1, 30 to 60 was zone 2, 60 to 90 was zone 3. We had them rotate to each side while we were standing behind them, and we would mark the location of the dowel and which zone it was in. So as you can see here, our sample score, left zone, we would put a 1, 2, 3, right zone, 1, 2, 3, symmetry being the difference between the 2 and if there is any pain. So here we see a sample assessment for the thoracolumbar rotation test. And once we get all this data, we've got to interpret it again. What are we looking for? Are they having decreased total trunk rotation? Are there asymmetries on one side? Do they have increased total trunk rotation? And even more, if they've got increased lumbar trunk rotation, we know that that leads to changes in the articular surfaces and the discs between the lumbar. Again, the way that we set up our test, we had 3 different zones, 1, 2, and 3. If someone were to fall into zone 1, we know that they have between 0 and 30 degrees of trunk rotation. If they fall in zone 2, they've got between 30 and 60 degrees of rotation. And if they're in zone 3, they've got 60 or more degrees of rotation. At this point, we weren't really sure what to expect from this test, so we weren't too specific on the exact measurements, and we felt zones were a good way to implement this test the first time. Because we know that if someone's in zone 1, they've got decreased total trunk rotation. We're looking for somewhere between 40 to 50 degrees of rotation, depending on the athlete, especially in our sport. So if they're less than that 40, we know they've got decreased. Zone 2 is anywhere between 30 and 60. We know that they're probably in a decent range of rotation. But if someone is in zone 3, that means they've got more than 60 degrees of rotation on one side, which could be an indicator of excessive trunk rotation, which could lead to stress, like we talked about on those surfaces and the discs between the vertebrae. So if we saw someone and we noticed they had an increased total trunk rotation, we would need to further assess them to see if that rotation is coming from the thoracic or the lumbar spine. It's a simple test, stabilizing the thoracic spine on the back of a table, basically a Thomas test, having them rotate their knees to each side. really isolating the lumbar spine in that rotation. And we would measure the rotation of the spine there. So now that we've got all of our tests completed, we can kind of put them all together, see what we're looking at, how we can build a program to fix these issues and these compensations. Starting off with the dorsiflexion, their foot turns out and their knee to wall test was pretty poor, which would indicate that they've got an issue with dorsiflexion mobility. Just based on the knee to wall, we're probably looking more orthokinematic or musculature based over a previous injury, since there's not a large deficit on one side to the other. The next compensation is that the knees are falling in. And since we know that this individual has poor dorsiflexion from the two tests before, we're probably going to attribute those knees falling in to that lack of dorsiflexion. As that kinetic chain works from the feet up, you're going to see compensations go. And we're thinking that not being able to get into dorsiflexion is causing those knees to cave in. The next step would be the arms falling forward. Again, just through our observation, we see that their lifting program, we know that they don't do a lot of mobility, transverse plane issues, or work. So we're going to chalk this up to tight musculature as well, causing those arms to fall forward. Now for the hip shift, this seems to be musculature in nature. We don't see a large discrepancy and asymmetry in the knee to wall test. They're pretty close, so they're not leaning to one side because they don't have dorsiflexion on the opposite side. They're actually leaning to the side where they have less dorsiflexion. So this is probably coming from musculature at the hip, maybe even into the thigh. That's causing that weight shift to their side. And then trunk rotation pulling both directions. This kind of confirms our arm falling forward, tight musculature in that thoracic area, up arms and into the shoulders. So just a quick review where we're at and what we've covered in the last little step. So we start off, what are we trying to affect? Find that injury dysfunction, and we did those 4 issues that we're trying to affect. Ankle dorsiflexion, medial knee displacement, thoracic rotation, and muscle imbalances. We've gone through those and identified them and broke them down into simple ideas and figured out what was modifiable. And then we set our goals. We wanted to increase dorsiflexion. We wanted to address muscle imbalances that could be causing stress through the kinetic chain. And we wanted an assessment on thoracic rotation to see if they've got too much or too little. Those risk factors for injury, like we talked about, lack of dorsiflexion can lead to medial knee displacement, which can lead to ACL injuries. And we're not trying to prevent ACL injuries. We're just trying to increase dorsiflexion, maybe to lessen the chances of that occurring or be in a better position to not have that occur. We selected our test battery, which was the overhead squat, the knee to wall, and the thoracic trunk rotation. We got the data from that. We just finished interpreting it, what they all meant, put them all together. And now we get to the fun part, the intervention. So for the intervention, don't try to memorize all this. It's impossible. But just know that you can go back and reference these once you've kind of got your data and interpreted it. This is all built off the NSAM model. And we know from our tests before what musculature might be overactive and underactive. So we've got those here listed, and they're the same from the slides before and what we've identified from our test. And there's 4 steps in this process to create the overall program. Step 1 is inhibit, step 2 is lengthen, step 3 is activate, and step 4 is integrate. So here we've got step 1 and 2. Inhibit by means of foam rolling. Shut those muscles that are overactive off. Try to get them to relax so that you can lengthen them in step 2. So we want to foam roll the lateral calf because we know that's overactive. The adductor, the lateral leg, and the lat, all those have been identified from our test as being overactive. We want to shut them off, inhibit them with step 1. The next step would be to lengthen those exact muscles. We know they're overactive, so they have a tendency to be short, and we want to lengthen those up. So we would do a knee bent slant board to get that soleus. leg across to get the lateral structures of the hamstring. TFL, we want to do a frog stretch, something for the adductors, and then a lat stretch. So we turn those off and then we lengthen them so that we can then get to step 3 and activate the opposite muscles. So these muscles have all been identified to be underactive, which means you need to turn them on. So they have been identified as being lengthened, and we need to shorten them a little bit. Again, these are the same muscles that we talked about before, and what we would do are just some isolation exercises for these specific muscles, 2 by 10 by or 20 or 30, really trying to get that neural drive to these underactive muscles. We would try some medial rotated calf raises to hit that medial gastroc, do some TKEs for that VMO. To address the weight shift, we'd be looking at left-sided clams only, so we'd only have them perform the clam with the left hip, and then have them switch over and do the right side adduction to activate those adductor muscles on the right side. And then some high pull, some internal external rotation, just to kind of hit the trap, rhomboids, rotator cuff, things like that. And then step 4 is to integrate. So we have inhibited, we've lengthened, and we've activated the opposite sides. And now we need to do an actual movement that puts it all together. And some combined exercises, examples, maybe a step up to a TKE, a row to rotation to overhead press, some single leg RDL Captain Morgans, and a heel touch with a medial band pull. Again, these are just combined movements to now integrate these turned off and turned on muscles that we've just worked through. So now we've got that, we kind of just put it into a sample program that we would give the athlete. Each of these athletes are going to be individualized. There's going to be different exercises for each of them, different things to foam roll, different things to lengthen, different things to activate. So we would put this all together. And I know that the previous slides all seemed like a lot, but it really is this simple, just identifying some muscles that need to be turned off, that need to be stretched, that need to be activated. And here we've got an example of 4 each. We've got 4 things that they need to foam roll and 4 exercises that they need to complete. And that's their injury prevention program, specifically addressed to their needs, not some blanket exercise. Again, this isn't something that's going to take them a lot of time. We had 15 minutes to complete this, and I think we were able to accomplish a lot in those 30 minutes a day versus them just going back to their room and doing nothing. Another thing is this would be a great warm-up for someone post-surgery. You identify some of these needs, they do a warm-up like this, then you've got them in a primed state to perform some strengthening exercises and not have any issues with creating bad habits. So at this point, we have given our prevention programs to all the athletes. This is after they've been retested. The initial test was done in June, the post-test in October. They had been working hopefully 2 times a day at these programs that we gave them specific to their needs. And as you can see here, we had quite a bit of green. That means increases in dorsiflexion. This is just the knee to wall test here on the left and the trunk rotation on the right. And for those measurements for the knee to wall, we had a significant increase for quite a few of these athletes. Again, we weren't looking to decrease or eliminate concussions or ACL tears or ankle sprains, but we know that dorsiflexion is a risk factor for other injuries. So we wanted to address dorsiflexion, and we were able to do that and get an increase. So we reached our goals with this program. Now with the trunk rotation on the right, we're a little confounded. We didn't really see too much significant changes. A lot of yellow there. A lot of people staying in the same zones. So we readdressed this in the next round and got a little bit more specific in the measurements. But that's part of the process, right? You're not going to get what you want every single time. You just got to build that structure, test, compare, and then make adjustments if needed. So just to end here, a couple talking points that that I've thought of and have been brought up. And the main one is when you test, when you do these overhead squats and knees, do you do it when they're already warmed up? so that these imbalances are possibly more pronounced because they're already moving around, and those imbalances are habitual. You see those prevalence maybe a little bit more after they're warmed up versus doing it when they're cold, and see if you can catch those imbalances before they've warmed up. There's not a lot of data out there on best time to catch these imbalances, whether that's before they're warm or after they're warm. So it'd be an interesting thing to kind of look into, doing these tests for specifically the muscle imbalances, not necessarily the range of motion tests, pre and post warm up. And then our program, just due to the feasibility of it, the language barriers, the time, and trying to explain all the different types of stretching for different muscles, we just did static stretching. Now you could do partner, you could do PNF. There's other ways to stretch, and for that component of our program, we probably could have improved and maybe saw better results for our lengthen and inhibit areas. But that's for another time. I've got the paper references here. If you're really interested in looking into the research that I found and wanting to start this or look more into it, all the information is here, at least the papers that I referenced in this. They might not be in the right format, but we'll leave that for another day. So with that, I appreciate you guys making it this far. Hopefully it gave you some ideas on how you can develop your own and implement your own injury prevention program, or maybe just change your mind on the overall thought of injury prevention. Like I said at the beginning, there are multiple different ways of injury prevention, some that you might not even know. This is just another way to kind of hit that domain that the athletic trainers have in their practice analysis. So again, thank you. And you can reach out with any questions if you need.